Bismillahirrahmanirrahim. Welcome fourth year EMP students. This is the first recorded lecture prepared and presented by me, Dr.KHALED DIAB. I am an OB/GYN professor at MANAMGEMNT University Hospital. Hope you find it useful and helpful. I will share with you the following slides that will review an evidence-based update on clinical management of abnormal uterine action, uterine dystocia, and labor progress abnormality. By the end of this presentation, the student should clearly understand the following ILOs. The presentation will follow through the following headings, titles: Overview, Uterine Activity, Uterine Dystocia, Normal Labor Progress, and the 4 new abnormal labor progress abnormality. The student is advised to revise the basic physiology related to the 3 phases of parturition, 4 stages of labor, and its subdivided phases. Furthermore, a clear understanding of the classic labor curve of Friedman, showing sigmoid curve of cervical dilatation, and the fetal descent curve is essential before hearing this lecture. The optimal cesarean section rate, as expected by WHO, is 10 to 15%. In any hospital, any rate below 10% or more than 50% need further analysis, and its root causes needs a logic explanation. Other labor outcomes should be analyzed for any condition that complicate labor, as shown in the following table. It should be also noted that failure to progress or dysfunctional labor represent almost 50% of emergency cesarean section rate at any hospital. Normal labor, also known as eustocia, may be defined as a spontaneous labor through the normal birth canal for a single mature living fetus presented by its vertex in the left occipito-anterior, unaided, uncomplicated, and unduly prolonged. Dystocia, derived from the Greek word meaning difficult labor, may be defined as any deviation from normality, as shown in table. In the medical dictionary, it is subdivided into maternal, fetal, and placental dystocia. Labor with failure to progress may be defined as labor characterized by slow progression and eventually labor arrest. Usually it is overdiagnosed and mostly diagnosed as cephalopelvic disproportion or fetopelvic disproportion, which classically results from either 3 P's, the passenger or power abnormalities. Dysfunctional labor may be primary, also known as uterine dystocia, or secondary, which results from abdominal muscle weakness. In clinical practice, uterine contractions are usually assessed qualitatively, either manually or via external tocodynamometry. Quantitative assessment may be achieved via intrauterine pressure catheter along with internal fetal monitoring. Details of monitoring has been already given in previous normal labor lecture. Verification of clear understandings of the pros and cons of each method may be discussed in the next face-to-face session. As shown in the following table, uterine dystocia may result from either an inefficient or an over-efficient uterine activity. For inefficient uterine activity, the uterus may be too lazy, primary inertia, too frantic, incoordinate, uterine action, or too tired, secondary inertia. For over-efficient uterine activity, the labor may be too easy, precipitate labor, or too difficult, obstructed labor. Furthermore, there are special forms that will be discussed at the end of the lecture. Classic intrapartum labor monitoring include maternal, fetal, and labor progress assessment. Frequency of assessment is related to the stage of labor and other factors. Labor progress assessment is done by pelvic examination, measuring not only cervical dilatation and effacement, but also fetal descent, rotation, and increased flexion. Transabdominal sonography and transperineal sonography has been used for assessment of fetal position and station, especially in obese women. The Friedman curve, as shown, and its norm established from Friedman data historically, has been widely accepted as the standard for assessment of normal labor progression. Philpott and Castle in 1972 introduced the concept of alert line and action line, and the well-known Partogram was used for clinical management of labor. The following figure shows how the Partogram is filled. The following figure shows how the Partogram is interpreted. Recently, Zanning and others have proposed a contemporary curve as shown, and norms that are different and are actually slower from those cited by Friedman. The difference between Friedman and Zanning labor curve will be discussed in the face-to-face session. Furthermore, clinical use importance of the Partogram will be addressed. The concept of active management of labor was first implemented by O'Driscoll and colleagues at the National Maternity Hospital in Dublin in 1968. This management system contained both organizational and medical component, with physicians supervising normal spontaneous labor in nulliparous women and intervening only when labor progressed slow. Active management of labor is a system designed to ensure labor progression and intervene to decrease dystocia, particularly in the first stage. The benefits of shorter labor and reduced maternal and neonatal infection rates without concomitant increase in other maternal and neonatal morbidities are proven benefits. A consistent decrease in the cesarean delivery rate has not been statistically demonstrated with active management of labor. Despite the use of early amniotomy, high-dose oxytocin regimen, and frequent cervical examination, patients seem to be satisfied with the shorter labor. Discussion of active management of labor component and its philosophy will be done in the face-to-face session. As noted before, classically, labor progress abnormalities are often results from the classic 3 Ps abnormalities. New evidence suggests that uterine muscle dysfunction may result from infection, inflammation, or vitamin D deficiency. Added to the classic 3 Ps, another 2 Ps may be addressed: provider practice and patient psyche problems. Examples of provider practice problems are very early ARM, or over-sedation or under-hydration. Patient psychological and cultural problems may result in labor progress abnormality, as in women with low pain threshold and those not receiving optimal or basic antenatal education during their antenatal care. Fear, stress and anxiety, lack of companion support, and unsupportive environment may affect labor outcome. Usually, a combination of all these factors are the cause of failure to progress. As regards effects and complication of labor progress abnormality, failure to progress may end in prolonged labor, maternal exhaustion, fetal with or without fetal distress, and obstructed labor. Also, precipitate labor may result in pelvic floor tears and later abnormalities, fetal and neonatal trauma, and later effects. As regards risk factors associated with failure to progress or abnormal labor curve, maternal factors include advanced maternal age, nulliparity, maternal obesity, epidural anesthesia, inadequate uterine action. Fetal factors include fetal macrosomia, post-term, occipito-posterior, high station at full dilatation, and cephalopelvic disproportion. Classic teaching according to Friedman curve, labor curve abnormality are classified into 7 disorders: 1 prolonged, 2 protracted, and 4 arrest disorders. The following figure states the limit and management of these disorders. Recently, Zanning has classified labor abnormality into only 4 main simplified abnormalities with clear clinical management: a prolonged latent phase, 2 active phase abnormality including a protracted and an arrest disorder, and a prolonged second stage abnormality. Discussion of each of these abnormalities and their management will follow.